Okay, so this study is funded by the National Institute of Nursing Research, and we started out with saying that nursing homes serve a very vulnerable population. At any one time, there's approximately 1.6 million Americans that live in the approximately 15,700 nursing homes. I say approximately because there's always some, closures and openings. Almost all of the nursing home residents are elderly. 66% are admitted with a primary diagnosis of dementia, and more than 40% have advanced illness. Prior to COVID, 380,000 people die of infections in long-term care facilities each year. And an infection control deficiency is the most common Centers for Medicare and Medicaid and Medicare Services inspection citation given. So infection prevention is really problematic. Infection prevention, diagnosis, and management is challenging in nursing homes for multiple reasons. A nursing home is a home for many people, and there's shared living spaces. You have shared dining halls, recreations, and they have been designed that way. And so it makes it very difficult. They're not the sterile facilities like a hospital. Diagnosing infections in nursing home residents is also difficult. And that's because the elderly have changed pathophysiology. They might have compromised physical barriers. Their skin might be frail. Functional impairments. There could be communication difficulties. For example, the person with dementia might not be able to tell you that they have burning with urination. And then there's lack of technology. There's not labs, and there's lack of access to advanced clinicians. Nurse practitioners, physician's assistants, and physicians aren't always there to help with the diagnosis. As a result, antibiotics, which are really a precious resource, are over and misused in nursing homes. This is one of the reasons I first got interested. Just one fact, just being a resident in a nursing home makes the individual high risk for having multiple drug-resistant organisms. Are you guys able to hear me with my gardener out there? Okay. If it gets too bad, let me know. I'll tell the gardener to quit doing the gardening stuff. But just being a resident in a nursing home makes somebody high risk for having an MDRO. And I thought, oh my goodness, this is just so terrible. Even before COVID, this is September 11th, 2019, we knew infection prevention was difficult and in nursing homes. And this was a New York Times article called Deadly Germs, Lost Cures. Nursing homes are a breeding ground for fatal fungus. And this is a photo of Mrs. DeBella, and she was in a nursing home in the Bronx. And she got Candida auris, which is so highly contagious. And it was the nursing home that caused the outbreak. And there is no cure for Candida auris, and it's often fatal. We know what happened with COVID. This is Kirkland, the nursing home with the very first outbreak. We just had an outbreak in the area where I live. There's an outbreak reported again yesterday. Nursing homes are a tinderbox for COVID-19. This slide shows all the long-term care facilities with at least one case of COVID. It's a few months old, and with COVID, a few months old is a long time. So, but let me assure you, there is a dot in every single state. And this comes from the Kaiser Family Foundation, and it's an analysis of available state reports and press releases. The pink states are the ones, the darker the pink, is the share of long-term care facility deaths due to COVID. The gray, they don't report that data. The range of percent of deaths as of April, again, a long time ago, is 19 to 73%. As of September 4th, there was about almost 500,000 COVID cases in nursing homes and about 80,000 deaths. That translates into 8% of the cases and 45% of the deaths. In Johns Hopkins Medical System, which is 5 hospitals, 21% of COVID-19 cases came from nursing homes and 50% of the deaths. Using data linking COVID cases with nursing home data, we found that nursing homes in which 50% of the residents were Black had more cases, 11.1% more cases, and 3.4% more deaths. Understanding how to prevent infections, how to manage infections, and how to give the care that is congruent with the individual is so important in nursing homes, and it's never been more important. But we've been doing it for a little while, looking at these things. And this was the first parent study, and we called it Prevention of Nosocomial Infections and Cost Effectiveness Analysis in Nursing Homes, or the PNICE study. And our aims were to describe the incidence of healthcare associated infections, or HAIs, in nursing homes across the country, investigate the relationships between the HAI and the resident care process, and qualitatively explore the phenomenon of infection control in nursing home. And we have an interdisciplinary team, and this was our first RO1 in this area. Our methods that we used for the qualitative, we used structured open-ended interviews. We conducted a national survey of nursing homes in 2014, and then we linked that survey to national data sets. The minimum data set is a special nursing home data set that is residents' clinical assessment, and this occurs on admission quarterly or when there's a major change in the residents' health. So it's clinical assessment done by MDS coordinators who are nurses, and it's mandated that this assessment's done. We had Medicare files, so we could look when the resident goes to the nursing home. And then there's another database, which we call CASPR. It's a Certification and Survey Provider Enhanced Reporting. And that's the facility characteristics, such as nurse staffing, and if there's CMS citations, those sort of things. So qualitative results, we went to 10 nursing homes across the country, interviewed 73 employees, and 5 themes came up. Residents' need. There was clearly tension between the facility being the resident's home and the need for effective easy for me to say, effective infection prevention and control procedures. Many of the employees, there was this idea of roles and training, and many of the employees involved in infection control had multiple other responsibilities, and they lacked formal training. Using the infection data, everybody said they used infection data, but how they got the data was varied. For example, we asked, some people used maps, some people, kept Excel spreadsheets, but it was varied across the nursing homes. Everybody was looking for external resources about infection prevention. They were looking for, they did not have the resources within their own facility, and they were looking to hospitals, to their local health departments, or the CDC.
Pat, excuse me, the noise is getting a little loud in the background.
Okay, thank you. Hold on just a second. Mike.
Somebody can sing if they want to.
Pat, you're still muted.
Okay, I'm so sorry about that. So the themes that we found, that people were looking for the external resources, such as the CDC or the local health department or the hospitals. And then everybody said they focused on hand hygiene, except how they focused on hand hygiene was often very informal. Like one person said, well, if I see a certified nurse assistant come out of a room and not wash your hands, I tell them. So it was very informal. The next thing we did is we looked at trends in infection prevalence. And the MDS, we had data from 2016 to 2013. As often is the case, they changed from MDS version 2.0 to MDS version 3.0 in 2010. And so I'll never forget the first time I saw this graph. You can see that this is UTI, all of a sudden, new version, it comes down and goes like that. This is pneumonia. This is the little triangles are the MDROs and wound infections. And this is the square here is septicemia. So everything was increasing in MDS2, and it was all significant. From 2011 to 2013, we saw that the prevalence of UTI, MDRO, and wound infections actually decreased, and viral hepatitis just sort of went up very high. What we learned from this is that clearly we needed to just be looking at MDS 3.0. We also were able to look at how many infections there were. And we've estimated based on the 2013 data that there was anywhere between 1.13 to 2.68 million infections occurring in nursing home residents annually. And you can see here that the UTI was the most common throughout, and especially in the after the 2002. And then that was followed by pneumonia. And it might not seem important, but it was important. Nobody had updated the estimates for so long. We were going from 20 years ago. Then for our survey, we used a stratified random sample. It was conducted in 2014. We got 990 surveys returned. Actually, we had over 1,000, but 10 of them were unusable, with a 39% response rate. And we linked that to the CASPR data. And we found that just like in our qualitative work, the person in charge of the infection prevention program had multiple hats. We also found that having a citation in infection prevention and control was related to the experience of the infection preventionist, and that is the person in control that runs their infection prevention program. And we found that less than 3% of these IPs are certified. We also found that, I mentioned earlier that antibiotics are a problem. We found that having a comprehensive antibiotic stewardship policy was very rare, and having one was also related to the IP's training. Katie Cohen, one of our doctoral students, won an award for her dissertation in isolation. She looked at isolation, and the evidence for isolation is based, or contact precautions, is based on the hospital setting. And using 96% of the nursing homes from 2011 to 2013, she had a sample of almost 200,000, 191,000 assessments that had an MDRO. And of those nursing homes that had an MDRO patient, only 31% used isolation. We also looked at, this is Jasmine Travers' work, looking at racial and ethnic differences of influenza and pneumococcal vaccination among the long-stay nursing home residents. Again, using the 2000 to 2013 data. She had over 100,000 residents in 742 nursing homes, and found that Blacks were less likely than whites to receive influenza or pneumococcal vaccinations, and Hispanics were more likely not to be offered a pneumococcal vaccination. So disparities were present. So the policy impact of this, in 2016, CMS final rule, which is that if you want to participate, you need to do these things, said that nursing home must designate an IP who is primarily responsible for the infection prevention and control department. That IP must sit on the Quality Assurance Performance Improvement Committee, and nursing homes must have an antibiotic stewardship program. The CDC just recently changed their isolation guidance, and there's something new called enhanced barrier precautions, which focuses on using barrier precautions when you're in a high-risk activity, such as changing a dressing. So we're sitting there and saying, okay, infection prevention's really bad in nursing homes. We found that out. It's time to write a new grant. And so this is when we changed our title and went to the study of infection management and palliative care at the end of life in nursing homes. And really started thinking about palliative care and the tension between infection prevention and quality of care and quality of life. So our specific aims in this grant is to describe the integration of infection management and palliative care in nursing homes and the associated facility, state, and regional characteristics, examine factors associated with antibiotic use, because we knew it was a problem, and examine factors associated with hospital transfer to infections among the elderly nursing home residents. You can see here's our conceptual framework, basic dawn obedient. We have structures of care, regional, state, county, and facility. And then palliative care and hospice care are important, as well as infection control and management. They're also structures and process. And then we were really looking at the integration of infection management and palliative care. How do we make sure that we're not overly treating and being burdensome to these people? And so we looked at hospital transfers due to infections and antibiotic use. So looking at hospital transfers caused or by with infection, there's a lot. And when it was caused by that, in the Medicare claims, we have present on admission, and you can have your primary diagnosis. And so you have a diagnosis of infection as your primary diagnosis. That's what we call caused by. With was, there's 27 other diagnoses that can be listed, and with was the infection was anywhere. And as you can see, when you look at all infections here, over the years, it's between 35 and 40%, and with infections is between 57 and 61%, and it's not declining at all. We had problems with our sepsis data, hence I have those blacked out. So then we conducted a second survey. So we had all the same things about the characteristics of the infection control program and in the IP, the training of the IP, but we added new measures about palliative care process, infection management process, and developed measures of the integration of palliative care and infection management. And that's the cover of our survey. So over time, between 2014 and 2018, it was less than 3% certified. It went up to 7% certified, and it was significant. The certification could be state or local training. A few did national through a professional society, and others, still a lot of them without any specific infection control training for the IP. When we looked at the changes in the infection programs over time, we came up with these indices on antibiotic stewardship, outbreak control, and urinary tract prevention, and then the infection preventionist training and education. And for those three policy groups, we had standard intensity indices. And it was the mean, it was 47 for antibiotic stewardship, 61 for outbreak control, and 52 for urinary tract infection. When we look at the change over time, you can see, it probably isn't amazingly, yeah, CMS has now mandated that everybody have an antibiotic stewardship program, and 65% of them said they did. You would think it'd go up. Outbreak control went from 55% to 68%, and urinary tract prevention went from just under 50 to over 56%. And these were all significant increases. So what's this telling us in 2018? Things are a little bit better than they were in 2014. Thank goodness for that, because we know what happened in 2020. Because of outbreak control so important, let's look deeper dive in here. Cohorting of infected residents. There was no significant differences in having policies about cohorting, and about 70% of nursing homes had that. Confining residents to room when they had an infection, there were more policies, up about just under 90%. Use of rapid diagnostic methods for case detection. That wasn't for COVID, but for others. More had use of that. More nursing homes said they could close a facility to new admissions. More nursing homes said they could instruct infected staff to stay home. Administering prophylaxis, that's mainly for the flu. More nursing homes were saying that. And more nursing homes were saying that they could quarantine units on which an outbreak occurs. So things were going in the right direction. When you look at the changes in infection prevention programs over time, in our multivariate models all showed significant increases over time, and the impact of the IP training, education, and responsibilities. And so the IP training is very, very important on all of these. We can see over time, this is the indicator for time right here. Those were always significant. The certification was significant. Where they got their certification was also significant. And their education was significant in outbreaks. It is a reason why I have recommended about IP training, and really worked very hard on some national recommendations to get that in place. This is a new paper that we just had out on antibiotic stewardship in nursing homes. And again, looking at the antibiotic stewardship programs, we found that the infection preventionist training, as well as participation in these learning collaboratives, which are called Quality Innovative Network Quality Improvement Organizations, were also important. And so they wound up, comprehensive antibiotic stewardship programs were associated with the QIN/QIO involvement and IP training and high occupancy. So again, CMS has contracts with these QIN/QIOs. They do learning collaboratives. They're helping nursing homes. Nursing homes need to look outward for resources, and they're one of the places that seems to be helped, as well as having the infection preventionists trained. Oh, there we go. When we looked at the QIN/QIOs, there's 14 of them across the United States. You can see the different colors. They vary with their resources and what they're focusing on. And we looked at an environmental scan to find out, what are they focusing on? And most focus on avoidable infection prevention and hospitalizations. Only 13 had resources about palliative care. It's just not out there yet. So I did mention that we came up with a measure of the integration of infection management and palliative care in nursing homes. And this is from our survey. We had 2 vignettes. Mrs. Davis been in your facility for 4 months. On admission, she was ambulatory and needed a total assistance with feeding. She was admitted with advanced heart disease, osteoporosis, and a right hip fracture, and Alzheimer's disease. She takes oxycodone, 10 milligrams every 6 hours for pain. In the past month, you notice she's eating less, has lost 10 pounds, and coughs when drinking. She no longer recognizes her family. We were hoping the vignette was saying we have somebody at the end of life with advanced illness. Over the past 24 hours, she's developed a fever, cough, and shortness of breath, and the clinical exam suggested an aspiration pneumonia. In your facility, how likely is it that she would have a do not resuscitate, do not hospitalize, do not administer antibiotics? She would have palliative care comfort measures only. The proxy would be asked how to manage this, the suspected infection. Medical providers would decide how to manage Mrs. Davis, and Mrs. Davis would be sent to the hospital. And then we had another scenario that this was pneumonia. Then we had another one that says that she's likely to have a urinary tract infection. Her urine looks dark, and asks if she has, and her family members asked if she has a urinary tract infection. She's not developed a fever because often you don't have a fever. A straight catheter would be used. She would be treated with the antibiotics. She would be treated only with comfort measures. So that's, and then this was all on a 3-point Likert scale, and that was based on another palliative care survey that was done. From that, our results, we came up with 3 different measures of integration of infection management and palliative care. And we did this using a factor analysis. And involvement was consider goals of care at managing suspected infection life, include residents, and these were not from these were other parts of the survey, include residents and resident proxies and treatment decisions. And involvement, had a Cronbach's alpha of 0.7. The mean was most of 73. Advanced care planning, these were all from the vignette. It had a Cronbach's alpha of 0.72. Wasn't around very, the mean of that was 34.1. And then routine practices was the third integration scale that we had, with a Cronbach's alpha of 0.68, and again, a very low mean. We did Pearson correlations between the infection management and palliative care and our integration scales. And they were all small they were significant, but they were small from the correlations from 0.11 to 0.25. So we really felt like we have a new concept here that's different than infection management. It's different than palliative care. It's really about the integration of the two. Unfortunately, we found very few characteristics. It was very idiosyncratic about if a nursing home would have integration. Oh, and our response rate, which I never told you, was 50% this time. We're doing better. We did look at integration and transfers to the hospital, and we did not use the 3 subscales. We just used a composite of all. And we looked at residents with advanced stages of dementia, CHF, and COPD. We used these 3 diagnoses because we have very good measures of advanced illness with them. And then we looked at all-cause transfer and transfer due to infection. We linked our survey to the Medicare claims, MedPAR, and then our MDS, and did multivariate regressions. We found that the intensity of integration was inversely associated with all-cause hospital transfer, as well as transfers due to infection in residents with advanced dementia. In residents with advanced COPD, integration was inversely associated with all-cause hospital transfers. There was no association in the CHF patients. And we think nursing homes, these data were all pre-COVID. Nursing homes may have difficulty managing shortness of breath symptoms. What's happening with COVID? The analysis is cross-sectional. We need further data. We need to know how to help nursing homes more. We also looked at cognitive function and hospitalization due to infection. Sorry, it looks a little bit blurry here, but you can see that cognitive function before and after infection, it when you're hospitalized due to infection, the resident's cognitive functions goes down and it stays down. And if they were not hospitalized, this is how it would be. I mean, they're declining cognitive function, but this is really a big drop due to the hospitalization due to infection, saying that treating these nursing home residents with the hospitalization is probably not in their best interest. We did look at, one of the recommendations. I was on this commission. Oh my goodness, I'm sorry about that. I was on the commission for safety and quality in nursing homes, and many of the recommendations are about infection prevention. I did not, I was very strong about getting things about having a full-time and trained infection preventionist, and and saying we need to invest in the workforce to do this. There was nothing about palliative care and integration, and I didn't feel like I could push that recommendation. This commission, I can't go over all the recommendations. There was 25 commissioners. There's 10 themes, 27 recommendations, and 100 action steps. But, I do think that our work, in my mind, is really push for the recommendation about infection preventionists. I want to get to the point where I'm recommending more about palliative care. So discussions, infections occur frequently in nursing home residents. Infection management is suboptimal, burdensome, and inconsistent with palliative care goals. It's unclear how best to implement and coordinate infection prevention, and strong evidence-based recommendations are needed. So this is what we want to do next. Don't know if it'll happen, but this is what we want to do next. We want to go back and do some qualitative work about infection prevention and control post-COVID, palliative care, and infection and the integration of the two. We want to do another survey, and we're going to look at more at how palliative care is delivered in the nursing home, as well as the evolution of the infection prevention and control, palliative care, and integration. And we could do that because we have the perfect pre-COVID data. We'd like to determine the cost effectiveness, actually develop a cost effectiveness analysis model of infection prevention and control, palliative care, and integration. And then last is to do a consensus evidence-based recommendations on the best practices for these. And we would do that doing a Delphi study. So that's where we are. Where are we with time? Oh, I got a little time. So one of the things that we did was we did a quick survey of some of our nursing homes about COVID-19 preparedness in the midst of the pandemic. And I was just talking to Leah Estrada, she's on the call, saying, I just got an email. This was just published like in April or something like that. It's already got 12 citations. It was a quick survey. Only 56 people responded. And we asked everybody to do, it must have been published in the end of April because we did the survey in the beginning of April. We asked everybody that was only open for 1 week. It's like, if you want to respond to this survey. The good thing is we did sort of look like the rest of the nation as far as where it was in the Midwest, Northeast, and South, and the percentage of for-profit and non-for-profits. And what we found, apparently I don't have another slide on this. What we found was staffing was problematic, and everybody was having problems with PPE at the time. They just didn't know what to do. So I want to thank NINR for our funding. They were kind of thankful that they invested on something about infection prevention in multiple healthcare settings, and they had our work up on their website for a while. And of course, it's not one person that does this. It always takes a team. And I got to say thank you to my team. They've been great. So questions about palliative care and integration of palliative care, discussions. I'll move you guys back over here and I can stop screening. Oh, okay. Any thoughts, any questions?
I have a question, Ms. Betsy. So Pat, were you able to even look for preliminary data about the cost effectiveness? Just if you could imagine, knowing what it costs to send somebody to the ER, did you take a peek at your current data to see if you could pilot that at all?
We haven't looked at that. There has been 2 cost effectiveness analyses that I've found for palliative care in European countries, nothing in the US. Both of them found that, offering palliative care in nursing home is, very, very cost effective. Nothing in the infection prevention integration. So it would really be novel to do that. We hypothesize it's very cost effective, but it also, one of our costs is going to have to be the education of the infection preventionist. That's going to be a cost. And I don't know what I'll recommend, if I get to do this study for 4 or 5 years from now, but infection prevention, there's a lot of things that are similar to, what an infection preventionist in a nursing home and hospital need. They need to know about HVAC systems. They need to know about different organisms, they need to know about disinfection. But I think the infection preventionist in the nursing home also needs to know more about infection management and palliative care. I think they need to integrate it. And there is a slight worry with all this focus on infection prevention that the palliative care part won't be, people just won't care about it, and that's burdensome for people. And it's not always what their care goals are. So I hope we get to do the next step in this work. I think it's very important.
Yeah, my real question was going to be about what's the cost of training or having an infection preventionist.
Yeah. And that, that's got to be a cost that we put in. But I also think that, the scope of work for the infection preventionist might need to be slightly different, for the elderly and, versus the infection preventionist that's working in a, children's hospital or something. Anybody else? Any other thoughts? Any critique?
Pat, this is Jing. Can you hear me?
Yeah.
Yeah. So just follow up what you just said regarding the training on the infection preventionist in nursing home. Do you know the current training, maybe like CIC? Do they have a specific content related to the palliative care or maybe the end of life?
They don't.
Period? They don't.
So,
okay.
Not for the infection preventionist. That they have focused on. The Association for Professionals in Infection Control they are looking at this right now and going to come up with the criteria for the scope of practice. And I'm on that committee, so I'm hoping I can get to talk to them about the need for specifics around geriatrics that would include an advanced illness, which is going to be different. And but no, they don't have any differences. The CDC has a training course out now, but it's all about infection prevention. It's not about palliative care at all. And when we first got into this, Susan Mitchell out of Harvard we brought her on as a geriatrician. She thought they were just 2 silos. Here we have infection prevention, here we have palliative care. The 2 never meet. And I think we're still there. And it's not really necessary. It's not right. and we got to do better in both of them.
Right.
Truly do better in both of them.
Yeah, another question is related to the statistic you cited on the COVID-related case and COVID-related the mortality rate. I find the Hopkins data is slightly higher than the national data. Is that because the Hopkins, the location, they are more like minority patients?
I don't know what the difference is, why they have 50% of the cases, or 50% of the deaths, and where the nation says it was like 43 or 45%. I don't know. It could be due to the diversity of the population and more comorbidities, but the specifics, I don't know.
Okay, thank you.
Yeah. Anything else? Okay, well, I want to thank everybody for being here. Our next talk is not for SIP-E. Ashley's got to help me with this. I was preparing my talk.
No problem.
I think we're done for a little bit.
Yes, our next talk is actually scheduled for this spring, not until February. So this will be our last SIP-E presentation for the fall.
Yeah. And we got a good lineup coming in the spring. Ab Brody is talking. Jean Kuttner's coming, and she's the head of the Palliative Care Research Collaborative. And we're going to have another workshop, and so more to come. I want to thank everybody for being here today. Anything else? Good to see everybody. Okay, take care. Bye-bye.